Welcome. I'm Dr. Bill Reichman, the president of the International Psychogeriatric Association, and it gives me great pleasure to welcome you to this webinar being sponsored by IPA and our colleagues at INTERDEM. You will hear several talks throughout the webinar, and there will be opportunities for you to ask questions, which I'll return to in a moment. We're blessed to have the following speakers: Professor Carmel Pisa, Professor Mira Vernoy, and Professor Diego DeLeo. The topic is social distancing and its impact on the social and mental health of older people. Now let's talk a little bit about our sponsors. IPA. IPA has stood for better mental health for older people for more than 30 years. Our organization represents a membership of the leaders of our field across the world and across many disciplines. Through our educational activities, our scientific meetings, and our cutting-edge publications, IPA promotes better mental health for older people all over the globe. We represent a commitment to serving the broad spectrum of issues, perspectives, and opportunities and challenges of the field of geriatric mental health. Now let me say something about INTERDEM, our partner. INTERDEM is a pan-European network of researchers collaborating in research on the dissemination of early, timely, and quality of psychosocial interventions in dementia. Their purpose is aimed at improving the quality of life of people with dementia and their supporters across Europe. And now for some housekeeping tips. I urge you to use the question and answer button to ask questions anytime during each presentation. At the end of each presentation, we will have nearly 10 minutes to respond to your questions, but I would urge you to start posting your questions during the presentations themselves. Now keep in mind that all of you as attendees are muted and the chat feature is disabled. Now, as can happen, if you have technical difficulties, try logging off. So if you're having technical problems, try logging off from the webinar and then logging back in and see if that resolves the issue. Also keep in mind that this webinar today is being recorded and its entirety will be posted on the IPA website. Now for our first presentation. This will be a vlog provided by our colleague Ellen Sano, an assistant professor of emergency medicine at Columbia University Irving Medical Center in New York in the United States. And Ellen will be joined by Karen Miranda, a colleague of hers, a clinical nurse manager in the adult emergency department of New York Presbyterian Columbia University Irving Medical Center, also in New York in the United States.
I drive to work where I used to take the subway. It's not really safe anymore to take the subway. There's a lot of subway workers out. And so you'd have to be a lot closer together with other passengers. It's not reliable either. So I brought my car into the city. And the nice thing about being in the car is you don't have to wear a mask. In New York City now, when you're outside, you need to wear a face covering. So I stay 6 feet away and I wear this. But now I'm going to work. So now I'm going to put on this and I'll walk across the street with this on to get into work. Well, I'll switch to another N95 along with a face shield and goggles.
I'm an emergency medicine physician. I have been working in clinical medicine for almost 30 years. I've been an ER doc here at Columbia University for almost 10. Most recently, I've been involved in geriatric emergency medicine research. But when the pandemic struck in New York City, all research was stopped. Our geriatric population has suffered the most during the pandemic. Not only was the mortality the highest amongst older patients, but for their family members and the families it's been a frightening and anxiety-provoking experience. Because of the infectious disease issues, families were not allowed to come in with their loved ones. I think the one scene that really drives it home for me is there was a time I had to go out to the front lobby to meet with a family member to show them how to use a pulse oximetry. As I was waiting for her, I saw this scene that I'll never forget. Families were bringing their loved ones up to the front desk. And most of these patients were older, having difficulty breathing. And that's where the families said goodbye. The problems of anxiety and fear have continued. And now, as we recover from the pandemic, many people are afraid to come to the hospital. They're afraid to bring their loved ones to the hospital. And so the tragedy of the COVID-19 pandemic continues, and the fear, anxiety, and depression in our community, and especially amongst geriatric population and their families, continues.
This is Karen Miranda. I am a clinical nurse manager. Been working here for the last 8 years, but I've been the clinical nurse manager for our geriatric program for almost a year now. The biggest change is the no visitation rule that we have at this time. So a lot of our older patients, majority of the time, they would come with family members that know more of their care, but now that we're not allowing any visitors, that's made it difficult on our end to care for them. Story, it was a patient. He was about 90 something. We knew he was palliative care, end of life. Just very lethargic, hard of breathing, on and on rebreather. We were rushing to get him upstairs to the palliative care unit so we can make space because there was no capacity in the emergency department. So we're rushing, trying to get him ready, and then the doctor, his admitting team comes in and says, "Hey, can you just wait a few minutes? His granddaughter wants to talk to him via FaceTime." So normally when we get presented with these situations, we're like, well, they can talk upstairs. We need to move. But given the circumstances, we decided to wait a few minutes. So the provider was able to call the daughter up on FaceTime. The minute, and I was there, I was right next to him. The minute he heard her voice, he just perked up. He started talking to her, recognized her, which to me just said a lot, because before that, I was walking back and forth, and he just seemed very out of it, very lethargic. We would try to get response from him and we would get nothing, but the minute he heard his granddaughter's voice, it was just a pivotal point in my nursing career during this pandemic.
Our first formal presentation will be by Professor Carmel Pisa. The topic is older persons' human rights and the COVID pandemic. Are they compatible? Professor Pisa is from the University of New South Wales in Kensington, Australia, Sydney University, and Capacity, Australia.
Good morning. I'm deeply honoured to have been invited to take part in this really important webinar, and most importantly, to be part of IPA's growing human rights agenda. Who better than us, clinicians working at the coalface of older people's mental health, to be human rights soldiers? I'm sure that you, as I have for many years pre-COVID, and now more than ever, seen things that have made you say, this is not right. Today is about helping you advocate for the human rights of your patients by expanding on this to say this is not right, it is a human right violation. In my experience, people do sometimes stop and take notice if you use a human rights frame in your protest. Our patients are perhaps the most vulnerable to human rights violations by virtue of multiple jeopardies of disadvantage: advanced age, frailty, mental and physical comorbidities including cognitive impairment, and often being segregated in nursing homes. Now, enough of why. This is a map of the Convention of the Rights of Persons with Disabilities, otherwise known as the CRPD. In blue, the blue states, both dark and lighter blue, show both state parties and signatories to the convention, which opened for signature in 2007. I think we can safely say that the majority of webinar participants come from a blue state. For us, working in old age psychiatry, of the 50 articles of the convention, the most salient are Article 12, which talks about autonomy, equal recognition before the law, equal legal capacity, providing appropriate support for decision-making, the expression of will and preferences, and safeguarding against undue influence and abuse. Article 14 refers to the liberty and security of the person, 16, freedom from abuse, 19, inclusive community living, 22, respect for privacy, and the big two, Article 23, respect for relationships, and 25, equitable access to the highest standard of health. Despite the widespread dissemination of the CRPD, the existing human rights landscape is pockmarked with craters of violations. There is invisibility of older persons' specific needs in human rights systems, which tend to talk generally about disability. There is a big implementation gap between the articulation of human rights values in these frameworks and the actual enjoyment of such by older people. We don't walk the talk, particularly when it comes to older people. It is for this reason that there has now been an ongoing debate by the UN Open-Ended Working Group for the possibility of a new UN treaty specifically focused on the rights of older people. What is the biggest driver of this? Look around you. Chang's systematic review of this year showed that ageism is alive and well in health in 45 countries. And I don't need to point out the rampant pandemic ageism present now. Leah Ayalon has expounded beautifully on this in this recent International Psychogeriatrics free online paper. The typical zeitgeist at present regarding the worth of older people is reflected in protests such as, "Why are we sacrificing our lives for you? You should sacrifice for us. You have already lived your life." These violations merely exacerbate existing inadequacies in aged care. Tales of neglect abound, such as in Australia's recent Royal Commission, but this is nothing new or unique to Australia. Much of the focus during the pandemic has been dead or alive. And certainly the appalling numbers of deaths in nursing homes, which in some countries didn't even count in mortality numbers, is the number one horror. The right to life, as articulated in other human rights frameworks, and the right to health, as articulated in Article 25 of the CRPD, are certainly our highest priorities in the pandemic. And I'm mindful that I'm preaching from the luxury pulpit of Australia, where we have done well from a COVID point of view. But this doesn't excuse us. There are other human rights at stake. Article 14, the liberty and security of the person, particularly relevant to people living in nursing homes. Article 19, what are the rights of our community dwelling patients to equitable access to ongoing mental and physical health care, including dementia care, can only be mediated by adequate PPE provision of staff and continuing service provision. Respect for privacy needs to be maintained while we enforce safety. Finally, Article 23, respect for the home, the family and relationships is a priority in the face of COVID-enforced social isolation and loneliness, the very topic of today's webinar. What can you do? Number one, if you can have a say, have it. I do, whether I'm listened to or not. I'm currently involved in planning a district's response to the COVID pandemic, and the HR word, the human rights word, is uttered frequently by myself. Number two, the importance of autonomy and free and informed consent is a long-standing issue with respect to the overuse of psychotropics and our global problem with obtaining consent for such. Please reference human rights and use terms such as will and preferences in your clinical notes. It can be very useful to justify such in your medical decision-making. Number three, human rights are at stake in every capacity assessment. There is a presumption of capacity for all adults. Don't assume a patient with dementia or schizophrenia lacks capacity to make decisions about COVID treatment or any treatment, and then automatically revert to carers or worse still clinicians to make decisions for them. Ask the patient first and assess if they do have capacity. Number four, if ever there was a time to aggressively pursue human rights, it is at the end of life. Authentic advanced care planning is supported by capturing will and preferences at the end of life and doing advanced care planning with competent patients, not signing people up as we're encouraged to do just to get our KPIs up. Number five, failure to meet will and preferences, Article 12, and to respect specific needs arising from disability, Article 25, drives most change behaviours in dementia. Number six, push for the human right for relationships and intimacy, Article 23, by mandating social connection for nursing home residents. Number seven, reference human rights when doing medical legal work. I do. Probably my most referenced right in my reports is Article 16, the right to be safeguarded against abuse. Number eight, call out ageism amongst our colleagues. Chang's paper that I referred to earlier confirmed what we see every day in health. Number nine, push older people forward. Give them voice in policy and planning. Number 10, triage must be based on individualised assessment, not diagnosis nor nursing home residency, and certainly not this nonsense about ED avoidance or exclusion for all patients with dementia or all patients from nursing homes. So that is the end of my rant. And it is a rant because I have been ranting for 10 years and occasionally I'm listened to. But if you join me, I might be listened to more often. Thank you so much.
Thank you, Dr. Pisa, for your rant. It was quite informative. The first question that we have for you is the following. Given the impact of the pandemic on older people, do you think this will have any kind of consequence for societal attitudes towards the elderly? For example, will it have any impact on ageism? Will ageism now go up, or do you think ageism will go down as a sentiment? What are your thoughts?
That's a fantastic question, Bill. Sadly, some 50 years after Butler invented the term ageism, it seems to be that ageism is rearing its ugly head even worse than ever. And you'd think that a terrible impact on older people would invoke compassion. And certainly, you know, it has in many quarters and been wonderful responses in terms of supporting older people all around the world in all sorts of contexts. But the sad thing is that I think that ageism is worse than ever.
It may actually be influenced. It may actually be influenced by jurisdiction a bit as well. Another question for you as well, Carmel, is When I trained in psychiatry, there was very little curriculum on how to embed human rights considerations in the care of our patients. What's your experience of how well the next generation of mental health professionals will be versed in human rights perspectives? And what do we need to do about it in terms of our trainees?
Again, another really interesting question. And that's why I use this word rant, because I often feel like a crazy woman screaming from the rooftops about this human rights issue, because in some ways it's often not considered our business, is it? It's certainly amongst right across from students, from medical students, registrars in training, human rights is not a topic. And in fact, to be honest, I've only pursued a human rights interest since the Convention of the Rights Persons with Disabilities was ratified around 2008 in Australia. So it's a very fresh concept for us to embrace. And I very much think that this is a space increasingly that IPA has been addressing and will continue to do so in the future. And I really welcome this. This is what I was saying. I'm so honoured to be able to be allowed to rant. And especially those moving personal experiences from New York just highlighted some of the issues at stake and how really good clinicians address these human rights issues just intuitively. It's just that we don't often have a name for it. Yes.
Yes. Well, one of our participants in the webinar now has another question for you, Carmel. So see how you can handle this one. The comment is this: the majority of patients with dementia have lost their capacity to make major decisions. For example, the need to be admitted to a nursing home. How do we deal with this if a patient with dementia does not consent to be admitted to such a facility?
Okay, well, I'm very wary of making sweeping statements about the majority of people with dementia having lost capacity. I think it's a very individualized issue. And as I said before, we can't presume that. I think that's the opposite of what I'm saying. I'm saying that we need to ask the person first and presume capacity. They have got the decision, and to understand why they don't want to come into a nursing home. And goodness me, if ever there was a reason why you may not want to go into nursing home, it would be now, wouldn't it? So don't presume that they don't have capacity, number one. Number two, unpack that and truly do. If that is the case, if there is reason to doubt that, what we call rebutting that presumption in the face of dementia, you might want to assess capacity. And then if they truly lack capacity, then in every jurisdiction there are different arrangements in place, some more autonomous than others. There's guardianship and law across all countries, and that's usually how we address this issue. It depends on the jurisdiction, of course.
Mm-hmm. Mm-hmm. Absolutely. All right. Well, there are several other questions for you, Carmel. So the next one, I suspect we're going to come back to this topic throughout the remainder of the webinar, but this question is the following. Okay, what about elderly in nursing homes? What are the best policies to implement to keep them mentally and psychologically safe during this pandemic? Do you have any thoughts about that?
Well, I think we're going to be addressing that today. I'm very proud because in Australia we've just put in implemented very rapidly a policy about what I talked about, mandating social connection. To me, making sure that older people in nursing homes are socially connected and still stimulated is as important as showering, and in fact, more important than showering. We're so focused on these things that often older people refuse. We're so obsessed with these such rigid routines in nursing homes and don't prioritise the more important issues of the right to have relationships and to be intimately connected and to have needs met.
Mm-hmm. Mm-hmm. It's been a real issue here in North America, where we've had to put in place visitation restrictions, so families cannot come and visit their loved ones, and the putative reason is to protect the residents from the loved ones bringing the infection into a facility. But I think there's a lot of debate on the benefits versus the risks of that approach. All right, well, here's another.
Yep, can I just add to that? Not only that, it's the autonomous right for older people to make such decisions. I think there's this terrible, on the one hand, we have abandonment of older people. On the other hand, we have this paternalistic, misguided compassion that we can make decisions on behalf of older people. I mean, I know there's also the reality and limiting factor of the greater good and the community, particularly within the nursing home, and the risks to the whole nursing home. But I think there is room there for a bit of autonomy. An older widow, an older spouse giving consent to come in, or a person receiving their spouse, rather than having these blanket decisions made for them without any autonomy on the part of the older person. And certainly when I talk about meditating social connection, that may not be face to face, it may be in exceptional circumstances, but it also can include a whole ways of making connection. But I think connecting an older person with their loved one, particularly somebody who's used to having a visit from a spouse every day, as I keep saying, is more important than having a shower every day, frankly.
Yeah, and in some of our facilities, at least here in Canada, the family members come in and really do assist with care, particularly feeding assistance. So barring families from coming in has presented some logistical challenges in many facilities as well. Okay, we're just about done with our Q&A period for your talk, Carmel, but I do want to read a comment that one of the attendees posted here. There are calls on older adults to lay down their lives to conserve healthcare resources during the pandemic. Our healthcare response to the pandemic seems to imply that older lives are worth less than older adults. This is a rant for me, too, as a fellow geriatric psychiatrist. And so then the question is, which we're going to return to during the rest of the webinar, what are your thoughts? What are all of our collective thoughts on this ageism in how we're administering healthcare?
Oh,
okay.
Who is that? Who was that lovely person? I want to meet them. Somebody else. See, I knew if I ranted, somebody else would rant with me. So thank you for that, and thank you. I'm not the only lunatic. It's wonderful.
No, you're not the only. You're a member of a big club here of ranting geriatric mental health professionals. Okay, I think with that said, it's going to be time now for us to move on to our next speaker. All right, well, it is a great pleasure for me to introduce Professor Mira Vernooy. Mira is a professor at Radboud University Medical Center in the Netherlands, and she is the chair of the co-sponsor of this webinar. She's the chair of InterDem. Her talk today is the risks of social distancing for older persons.
Hello, it's weird to speak to you without seeing you, but I know you are there. We are virtually connected, and I would like to use this occasion to share knowledge and thoughts on the risks of social distancing for older persons. Social distancing is the key strategy to fight the COVID-19 virus. Political decision-making includes consideration of knowledge of the virus, of the economy, but the social aspect of social distancing require much more consideration in political decision-making. Social distancing affects society and social life by changing our cultural habits. No more handshaking, let alone kissing, and we highly depend on the core value of solidarity between generations. The measures taken so far come with benefits to the virus spread, but also with risk for social, mental, and cognitive health of older persons. Social health is challenged by social distancing. Social health relates to reaching out to others, but social distancing restricts these possibilities. Social health also relates to others reaching out to us, but others have the same restrictions in reaching us. Social distancing deprives older persons from valuable assets of social health, such as the face-to-face interactions, by sharing emotion, by hugging, and just being in the same place. Face-to-face interactions have been replaced by e-communications. Technology is a great communication facilitator, but we need more than virtual contact. When actual contact with older people, with family, is no longer possible due to the COVID-19 measures, the condition of older persons can rapidly deteriorate. In long-term care facilities, there is not only a high virus outbreak, but also a high outbreak of loneliness. Dying alone due to distancing measures is the major fear, and no one wants this. The tragedy is that the very measure to protect older persons endangers their quality of life and even their quality of dying. There are also risks of social distancing for mental health. Research in previous outbreak periods learned that social isolation is associated with mental health problems such as depression and anxiety. More than 50% of Chinese people in the recent COVID-19 crisis rated negative psychological impact. 29% of the participants rated moderate to severe anxiety. And there are risks of social distancing for cognitive functioning. And I would like to draw your attention especially to these risks. Both from previous studies on quarantine periods and recent COVID-19 studies, we found negative associations with cognitive functioning. A risk that needs much more attention since social distancing will be mandatory for a longer period. As a social health researcher in dementia, the consistency of these results with those of dementia research alerted me. A striking finding is that the lack of social interaction is associated with incident dementia. Conversely, epidemiological data indicate that a socially integrated lifestyle had a favorable influence on cognitive functioning and could even postpone the onset of dementia. How to explain this potential of the brain to improve cognitive functioning? It's the plasticity of the brain. The plasticity of the brain allows activating pre-existing cognitive processes or activating compensatory approaches. It's called the cognitive reserve. And this is a very promising angle in dementia research. But what is the working mechanism in relation to social health? We hypothesize that social health can act as a driver for accessing cognitive reserve by using the social resources. And this hypothesis is now guiding two studies in dementia, one on the onset, one on social health related to the onset of dementia, and one on the course of dementia. It reflects hope on how to prevent dementia and how to mitigate its consequences. So this is a hypothesis of hope. And what we learn from this hypothesis and the data we know so far, that social interactions for humans are like water to plants. We really, really need it. But considering this hypothesis in relation to COVID-19, the hopeful perspective changed into one of fear and worries. And the worries related not only to the risk of social distancing for older persons, but also to the shifting intergenerational solidarity. How long can this solidarity go on? With an impressive intergenerational solidarity, the first outbreak wave of COVID-19 has been managed. But with this solidarity is shifting. A younger generation now want to resume normal life. And there are even suggestions made to exclude 60 plus persons from social activities in order to go back to normal life. Ageism is playing a role. In a very recent study in which tweets were analyzed, it has been found that almost a quarter of the analyzed tweets had an ageist content. Political decision makers are confronted with all these tendencies. And a key challenge in political decision making is to maintain this intergenerational solidarity and to provide tailor-made freedom for generations, for all of us, and to prevent social exclusion of older person. That's quite a task to achieve. But we can do a lot ourselves to mitigate the impact of social distancing. If you live alone, engage with a person, engage with one person close to you. That makes a difference. And if you feel lonely, take the responsibility for it. Don't wait till others come and save you, but take the initiative. And replace touching by giving words to your affection. With regard to mental health, if you have a depressive mood, reach out to others, especially when you think, I don't need any other person. You do need, and ask for help. With relation to cognitive health, what is remarkable, working very well, is the number of chats during a day. It's not only about sharing secrets or having a very intellectual debate, but it's just chatting, and the number of chats during a day, that has proven to be important. Another thing you can do is to organize leisure activities with other persons, because the challenges are in the direct social interaction. That's the thing that is feeding us. With regard to care, Alzheimer's societies all over Europe urge to visit people with dementia as much as possible. And on their website, you can find a lot of measures to deal with behavioral problems and also with caring problems. And a very good way of providing care is available. There is knowledge on it, and it's called palliative care. And in palliative care, it's key to know the needs and the wishes of the patients and to act upon it. In conclusion, social distancing is meant to save the life of vulnerable older persons, but it comes with high cost. This means that political decision-making in the COVID-19 crisis should not only include knowledge on the virus, on the economy, but also on the social, mental, and cognitive risks of social distancing. Social inclusion of older persons and of everybody in society is possible and feasible, and is rewarding both for older persons and for society. Thank you for your attention.
Mira, thank you so much for that presentation. And there's a multitude of questions that now are being posed by the attendees. So let's start with the first one. In many jurisdictions across the world, particularly in North America, there's been a lot of media attention on congregate senior care settings like nursing homes or retirement homes, settings in which older people are being cared for in large groups. And these have been the epicenters for the pandemic. In fact, in Canada here, as an example, I can tell you that almost 80% of the deaths due to the COVID-19 virus have occurred in these kinds of settings, 80%. So The question for you, Mira, is this. What's the future of these settings? Do the potential benefits of caring for older people in a congregate setting like a nursing home outweigh the apparent risks of infection and morbidity and mortality? What do you think about this?
Well, this of course is a very special situation. The thing is, do people like to live in long-term care facilities? And that highly depends on how these facilities are run. About too many long-term care facilities are run like total institutions. They are more or less excluded from society, and this is painfully evident now in this very situation. So I can imagine people don't like to go into nursing homes now, and it's in fact, it has turned out to be a dangerous place, but that also comes from the facilities available for nursing homes. It's not only the way nursing homes are run usually, but are run in this crisis. And it turned out that if there are facilities to give away protective material, they are the last in the row. First it goes to the hospitals, then to the community, and then to nursing homes. And there is very little education on how to deal with the virus risk in nursing homes. So this is a very special situation, and it's dealt with very badly, and this should never ever happen again. So if there comes a next wave, nursing homes should be much better prepared, and especially societies should be better prepared and to be more generous in protecting older people, because they are locked in, and it's meant to be protective, but it came with huge costs for the mental and cognitive health of people living in these facilities.
Thank you. So Mira, there's another question about social distancing, which really is vexing. So do your best with this one. And the question is this: how do we balance the need to protect the high risk that older people get from getting infected by social distancing versus protecting them from the adverse impact of loneliness and isolation? So how do you balance this, protecting them from an infectious disease versus causing distress through social or physical distancing? What advice would you give about how to strike the right balance here?
Well, now the balance was very much on protecting life, and there was very little attention for the other needs of the persons. So there is much more freedom. There are general rules which allow a lot of freedom to people living in the community, and a lot of possibilities to meet people, and there is the possibility, if the place is rather dangerous, to protect yourself. So my advice will be to benefit much more from the possibilities which are in place, and to follow the general rules. But within these general rules, there is a lot of freedom. And now there is, for instance, giving in the Netherlands the opportunity to meet with one person, so the same person can visit the person living in a long-term facility. So it's and there are and you can go into a garden when the weather is good, which is in many places now. So it has been proven that very recent information that that outside that being outside it's not dangerous, and the infection danger is not well, it's little. So that there might be an opportunity to meet other people. So there are opportunities, and please use these opportunities.
So Amira, let me share with you a comment that one of the attendees made, and then I'm going to follow it with a question from another attendee. But first, the comment. Remarkable, warm, and human address. It warmed my heart and soul. Thank you so much. Okay.
Thank you.
All right.
Thank
All
you.
right. So,
Thank you.
all right.
Yeah.
So now a question that's been posed by another attendee. Okay. We have a situation where community social workers are not able to conduct physical visits to those lonely older persons due to the current COVID-19 pandemic. Is this common, and how to overcome? So you could start, I guess, in the Netherlands. Has there been some reduction in home visits by companions or by social workers? And how has that been addressed in your country? And if you're aware of what's been done in other jurisdictions, please share it.
Yes. Well, there's a huge reduction of actual visits. But for instance, general practitioners, they do visits, but they have protective material. So that was in the weeks before. That was very, very important. And in order to resume visiting, well, the same goes for what goes for meeting all the time. So try to use the possibilities to keep at a 6 feet distance, but also if it's necessary, then have a visit or have a meeting. And it's rather exceptional. Still, it's exceptional here in the Netherlands, but it's coming back a bit. And else, well, it has been proven even in Italy that also people with dementia appreciate virtual contacts by Zoom or whatever. So you can do that also with people who are not used to it. It's better to make contact in whatever way, or use a telephone. Older people are so used to use the telephone, so there are much more opportunities to meet, and please use them. I want to repeat it. We need it like plants need water. We can't do without it.
Okay, now there's another question here for you, Mira, for you to consider. Okay, the attendee says, I am very concerned about the increasing intergenerational divides. What might be creative interventions now during the actual pandemic to reverse this trajectory and facilitate rapprochement even better? What do you think about that?
Well, this debate about intergenerational solidarity was started already before the crisis, and when I heard about it for the first time, I was astonished. It's the most silly thing I ever heard to have a kind of controversy between generations, and there is no need for it at all. We need each other, and it's not everywhere. It's a little group with a loud voice. So my advice is just continue the intergenerational contacts you have, and don't try to give too much attention to it, and try to live together as we always did, and not to be distracted too much by it. It's upsetting, but we should not let rule it over us.
Well, thank you, Mira, very much. I'm sorry there were so many more questions for you. Perhaps we'll get back to them later in the webinar, but thanks again for that really illuminating talk. Okay, so now it's time for us to move on to the final formal presentation in the webinar. And this topic is mental health, depression, loneliness, and suicide from COVID-19. It's provided by Professor Diego De Leo from the Australian Institute for Suicide Research and Prevention, the National Center of Excellence in Suicide Prevention, and the World Health Organization Collaborating Center for Research and Training in Suicide Prevention. Professor De Leo is associated with Griffith University in Australia, as well as Primorska University in Slovenia.
A very good morning to all of you, and thank you for asking me to be with you today talking about the tragedy of older adults in front of COVID, and particularly from what has been one of the theater most struck by COVID-19, which was for sure Italy. Italy is the country where I live at the moment, and Italy had a mortality due to COVID-19 or associated to COVID-19, which was very, very high. You can see in the slide that out of 32,000 people who died, and today is 18th of May, more than 11 of those people were older adults, and we had older adults that had an average age of all the deceased people of 79 years. So a real hecatomb for them. It is true that most of them, approximately 95%, based on figures of the Istituto Superiore di Sanità, which is the chief institution in Italy to deal with health matters. Most of them had a precondition. On the majority had at least one somatic diseases associated to the viruses. And for those who died with COVID-19, it has been calculated that they spent 10 days from being symptomatic to death. And the first 5 of these 10 days were usually spent at home. One of the other really tragic consequences of the COVID-19 was the hecatomb that was registered in nursing homes of northern Italy, particularly Lombardy, which is the region with Milan as the capital of the region. And in this very industrious and rich region, there were many people. Approximately a quarter of all residents in nursing homes died by COVID-19. These are a bit titles of papers that I put together with collaborators in these days, but most of them concentrated on the real problems that were originated by the COVID, particularly among elderly people living in nursing homes or even at home. We are all aware that most elderly people are very frail, and that being socially isolated, being quarantined, meant to be more exposed to distress and all sorts of increasing severity of mental disorder. Many people fear the worst because they spend most of their time during the day watching television. And in Italy, we were used to wait for the bulletin of 6:00 p.m. in which people from the government, from the civil protection, gave the figures of the day, gave the figures of infected people, those detected by the swab test, and gave the figure especially of those who died by the COVID-19. And many older adults were in excruciating wait for this data, clearly pointing out that the majority of the deceased people were among their peers, were other elderly people. And this gave rise to a number of phenomena which are quite peculiar among elderly people. Many of them fear to be hospitalized, not only to get the infection, but to be hospitalized because they didn't trust the therapies over there. They had information that there were no specific cures, that most people were intubated, that most people didn't get through the hospitalization, and they ended in intensive care units with very few probabilities of making through. The other main issue was the loneliness and the fear of being even more lonely if hospitalized, because there was no possibility of any contact with their dears and nears. There was no possibility of having any physical contact with them. And so they risked to see their relatives for the last time when the ambulance picked them up to carry them to the hospital. So this created a lot of anxiety, this created a lot of agitation, and among elderly people of Italy, the old generation of elders, seniors, most of them are very Catholic, and one of the most frequent requests from these people were rosaries to pray. And we can frequently observe people in their rooms or being told by relatives that they were praying all the time, that many of them were frankly agitated, that they were ringing more frequently than ever their GPs, and if GPs didn't answer, they rang for police. They called for emergency services, and they called to have some company, basically. Nobody could check really on their habitual medication, no controls, the usual controls by their caring physicians, and also there was the fear that many of those people could not have any contact with the outside world. And in fact, a very miserable event happened on a few occasions, that people at their home were not seen anymore or heard anymore by people, and they died in complete isolation, and their corpses were retrieved several days after they died, just because the bad smell signaled the presence of the corpses. Suicidal behavior were also reported as increasingly more frequent. Of course, we need to wait for having more definite indication on this phenomenon. But in the province of Padua, where I reside, there were several cases of suicide and suicidal behavior. And it's hard to say what brought these people to the extreme decision, but people preferred just to probably end the agitation and the fear, the extreme anxiety about their destiny and the possibility of being followed up by anyone, by deciding to truncate prematurely their lives. At least this has been reported by nurses of neighboring people of those who died. Another peculiar aspect is something concerning demented people. And demented people clearly had more problems than other people. And they were frequently helped through, for example, the availability of tablets, but it has been reported that those tablets to communicate with the external world on many occasions increased their confusion, so gave rise to hypokinetic delirium cases, and this was one of the recorded phenomena, together with the refusal of leaving the bed or continuing to eat. Of course, the care of these people was even more difficult and distressing than the usual. And Italy has also a peculiarity in which very frequently the assistance of the elderly at home is performed by what we call in Italian badanti, which literally means the carers. And these caring persons are people coming from East European countries, and many of them don't have a regular contract. And this meant that in the controlled imposed by the quarantine times, there were many police checks, and the assistance from badanti was suddenly interrupted. So many elderly people were found deprivated by their usual routine and deprivated by the usual carer. And this created more disadvantages, more problems, more difficulties for these elderly people. And so other issues concern the increase in smoking, increase in alcohol use, but especially, I believe, the most critical aspect was pharmacological therapies, not only psychiatric therapies, so pharmacological help, but medication for cardiovascular disorder, hypertension, anti-diabetic drugs, and all the usual therapy for those people. And so it's important to consider that for older adults these days of quarantine, of social distancing, of social isolation, were really a major distressing factors. Coping with that meant usually to sacrifice what could have been otherwise a counteracting agent for depression, for example, such as physical motion, physical activity. People were confined in their homes, and so they deconditioned their physical health through that, and potentially increasing in that way also the level of depression. It's clearly needed now for the day to come, because clearly the danger of COVID-19 has not ended as yet, and clearly the quarantine and the isolation time have not finished as yet. And we need to take an active care of these people, intervening with all possible means by organizing social assistance, especially through volunteers and the available social services, but also through our physician attention towards them with direct calls or visit as much as it's possible. During the acute phase of the pandemic, many helplines were created, but these helplines probably service more productively younger age groups of the population, because teaching a new telephone number, whatever toll-free or easy to dial, It's always a commitment for elderly people, and so for them, we need to create an assistant that goes beyond the usual routine. Another issue, and my concluding remarks, concern the organization of services for the future. We need to probably replan the organization of many nursing homes and retirement places, even because many older adults today are more inclined to refuse the admission to those structures on the recent experience base than to go to them. So if they continue to be dangerous places where the infection can be contracted more easily than elsewhere, probably many of these nursing institutions will go empty very soon. So we need to probably decide for a more community-based type of assistance, able to intercept elderly people before they reach the acute hospitalization stage. And so disseminating from the point of view of the territorial organization, a community-based organization, many more agency than what we had planned so far. And the same holds true for nursing homes. So the future needs to be reorganized in terms of this assistance, for sure. Thank you for your attention.
Thank you very much, Diego, for that very fine talk. And we have a lot of different questions here that we'd like you to address. So let me start with the first one, and it's this: the experience in Italy was just so terrible for Italy's elderly population. We're wondering, do you think that the pandemic will lead to changes in how the country of Italy approaches the care of its older adults? What do you think?
I believe, honestly, that this pandemic will change many things, starting from the way of thinking to the future, making us all to think that we are frailer than before, we are more fragile than before, unstable, insecure, and that we probably rely on systems of healthcare that needs also to be reorganized. We were particularly affected by COVID-19 in northern Italy, which is the richest part of the country, which is the most industrious, more populated part of the country, more polluted part of the country as well. And in northern Italy, there is the best of the Italian care. So many hospitals are very famous, and they attract people not only from the south and the central part of the country, but also from some neighboring countries. So a lot of attention has been dedicated to build these hospitals and to be receptive to very serious and acute level of care. The problem is that we neglected community level assistance. So we couldn't intercept people before they became too severely ill. And this is something that we need to improve, something that we need to learn from this lesson. The other level of modification is that we lack training, preparedness to disasters. And we were surprised, basically, by this pandemic. And we didn't find people ready to react. We didn't have the protections up to react. We even sent doctors and nurses which were positive to swab tests to continue working because we didn't have any other chance. This is terrible and needs to be rectified as soon as possible. Another problem embedded with that, which is preparedness to disasters, is that we didn't have the right number of intensive care units. So we were forced to build in a record time new hospitals, new intensive care units, or reconvert hospitals, which is something that we are paying today because we are realizing, for example, that the number of deaths due to cardiovascular disorders and myocardial infarction has tripled, and that the level of deaths due to oncology and to tumors have also increased because people were not receiving the usual level of care due to the primary concern for the COVID-19. And also those who preceded me have indicated the big problem of nursing homes. Nursing homes are now places where people don't want to go anymore. So we are looking to restructuring them and to provide a level of security that these nursing homes, many of them without a medical staff, without people capable of isolating in an efficient way people living maybe in small spaces, sharing rooms, so being automatically contaminated by the entry of someone who had the virus. So this issue of restructuring nursing homes and paying more attention to emergencies, to a possible second wave, for example, of COVID-19. We all talk about that, but we are not sure, and we hope it is not coming back, but it could be a possibility. So we need to get more prepared to that. And these are basic experiences and teachings that we need to learn and to implement as soon as possible.
So Diego, you touched on several really important topics, and I want to circle back to a few of them based on some of the questions now that are being posted by the attendees. And one has to do with how would you describe what the impact has been on the mental health of older adults in Italy during the first wave of the pandemic? And are there any lessons that could be applied if, in fact, what you said a moment ago is true, that there could very well be a second wave of the pandemic? So what can you tell us about sort of the state of mental health services to address older people's needs in this first wave, and how might it impact how Italy approaches this if there is a second wave?
I believe that we have indications for the moment, so it's probably too early days for making final convincing statements. But from what I heard from many colleagues and friends, and heard directly from directors of services, is that emergency admissions during the COVID related to mental disorder declined. Not many people attended emergency departments due to suicide attempts, for example. So there was a kind of a very marked decrease in numbers of suicide attempts during the most, how can I say, most unfavorable days of the pandemic. Now there is probably a different flow of things because the acute phase is appearing to be passing, and there is an increased number of admission to mental health units and to emergency departments. So it was a U-wave, a U-curved wave, and now we are witnessing, for example, an increasing number of suicide, so fatal behavior. And fatal behavior due to persistent fears, fatal behavior, due to people imagining that there is no more room for them and there is no more future from a financial point of view for them, which is the major outcome, negative outcome of this crisis. So it would be a disaster for many, many families. And we run a foundation in Italy dedicated to helping people with traumatic bereavement. And we had in 1 week 8 calls, and we are assisting 4 families just in the province of Padua, which is 1 million inhabitants province, with 8 suicide apparently due to difficulties and not having the money to provide level of care and not even food. And so the state has been very late in answering to the needs of people. So there is much to do.
So I want to keep you on for just another moment here, Diego, because there are some really interesting questions that we'd really benefit from hearing your perspective on. So one comment, one question is, in your view, you've worked in different countries. How could we demand better conditions from governments for the treatment of older people in this pandemic and avoid sort of a reflexive approach to medical assistance in dying or euthanasia? Do you have any thoughts about that?
Look, in my view, we have a big enemy that is called ageism. And it's very widespread. We should be much more aggressive in giving dignity to the status of being an older adult, and to pay care and attention and love to those who made our society. So the level of neglect, the level of abandonment, the level of uninterest or disinterest in this third age or fourth age, even worse, it's macroscopic. And this has so many consequences in the level of assistance, in the level of provision of goods, in the level of fight to loneliness of people, to give them some meaning for life, some recreation for them, keeping them part of the active society, where active is not just money-making society, but is a community that has a body, a community that has a unity. And this is very much missing. And the future doesn't look too pink in this regard. So it's important, because then the level of desire to die prematurely or having assisted suicide or euthanasia are exactly consequences of this level of things, the state of things.
Well, you know, Diego, you and Mira, certainly Carmel, myself, as well as perhaps all of you attendees, you know, are very focused on the welfare, the well-being of our patients, and of course their families. What we haven't talked about in the webinar is also how our colleagues, the other staff that are working in either congregate care settings or providing home care or working in acute care hospitals, how they're psychologically doing here. Because if their mental health is not very good, we can imagine that would have an adverse impact on the mental health of our patients. Just last question for you, Diego. Have you noticed in Italy or perhaps in your other travels the stress that this has put on care providers? And to what extent do you think in the post-pandemic period we might see signs of post-traumatic stress disorder in care providers when one of their patients spikes a fever or starts to have a cough? What do you think? Just share some observations about your fellow care providers and the impact it's had on them.
Bill, thank you very much for this question. Together with a friend and a colleague, we are just finishing a book on this topic, because the level of stress of carers, particularly medical doctors, has been monumental. And I imagine you are aware that we had more than 160 deaths among physicians and more than 40 among nurses. And these are just the official numbers. Probably the reality is more cruel than this data, but is an unbearable number of deaths. Imagine these people are doing the best possible, putting all their passion and dedication and personal sacrifice in working in very tough conditions with a huge number of people affected by the disease simultaneously, and not having beds, not having ventilators, not having proper clothing to defend themselves, not seeing that things were managed in the right way. And especially many of these colleagues who were frontliners, they reported that they went home alone in the night without the comfort of their family members because of the protection, of course. But they had in their eyes the 20 or more people who enter alive the day and passed away during the single day. And they never seen such a huge number of deaths. And it was incredible to them and very distressing, because they didn't know what to do, how to best fight. And clearly another important issue was what sort of therapy do we do? What do we give to these people? And so there were different souls, different visions. Do I give plasma enriched by antibodies, natural antibodies, if I have it? Or do I give the usual antiviral drugs that are probably useless? Are we waiting for some more powerful drug, but we don't have it? So people were basically in a lottery. This person will win and survive, this other, I don't know why, bad luck, will die. And so stress disorders were very, very much seen and quite usual, to the point that actually we are reporting some of these experiences in a book. Thank you for this question.
All right. Well, thank you very much, Diego, for your contributions today. Very much appreciated.
Thank you.
All right, we're now going to move towards some of my closing remarks and then some final housekeeping issues. I would really urge you now, as the webinar is winding down, to start to post on the Q&A any other questions that you have or comments you might want to make about some of the things that you heard today. One question which has been raised several times, not only today, but I'm sure where all of you live and work, and that is, when are we going to get rid of the term social distancing? Because I think many have appreciated, including the World Health Organization, that the real issue here is physical distancing to prevent contagion. And physical distancing doesn't have to mean social distancing. Right now, all of us are physically distanced, but thanks to technology, we're not socially distanced. And Mira also talked earlier on in her talk about just using readily available in most jurisdictions a telephone. For physical visiting, people need to keep their distances, and they can use personal protective equipment like masks. And that'll go a long way towards accomplishing some physical distancing, but also not at the expense of social connectedness. Just a couple of thoughts before we wrap up. First, we are inclined to think that the pandemic has caused all kinds of problems in the care of older people. I would suggest that the pandemic has not caused many of the problems we talk about, but it's actually revealed problems that existed pre-pandemic. For example, many older people before COVID-19 were socially isolated, socially distant. They had difficulty connecting with their relatives. They had difficulty accessing transportation, to get to the store to buy food, to see their doctors, to interact with other older people. I think the pandemic has not created these problems. I think the pandemic has largely revealed them, that they've always been there under the surface, but now they just seem to be so much worse. And we've talked today a bit about the weaknesses in congregate senior care and how it's exposed the vulnerabilities of the resident population. And what I would say as well, that the pandemic didn't cause these problems in these congregate settings or in long-term care. The pandemic revealed them. We have had facilities where we are crowding older people together, which compromises their quality of life, even when there's not a pandemic. We've had difficulty staffing these kinds of environments with people that are paid an honest wage for the very hard work that they do. In many of these settings, they're not adequately trained, not only in IPAC, infection prevention and control, but in all other aspects of care. And we've revealed how, through the pandemic, many of these organizations are not properly funded. The government doesn't support them well enough across jurisdictions, and they can't raise enough philanthropic funds to be able to provide the quality of life that the residents demand. I'm hoping, as I would imagine several of you are, that we will learn from this pandemic and do a much better job than we were doing even before the pandemic. And we will be more effective in lobbying for the kinds of supports we need out in the community to keep older people with their families and safe in their own homes. And where there is a need for congregate care, we will recruit well-trained staff, we will pay them an equitable wage, and we will be better prepared should there be not only a second wave of this pandemic, but other pandemics to come. So I'm going to stop there and just say to you that I wish you all the very best in the ongoing care of your patients and their families. As Diego said a few minutes ago, there's also a lot we can do as mental health professionals to support the emotional well-being of our colleagues who are on the front lines of care. Okay, now I just want to share with you some additional resources that may be of interest to you. Please check out additional vlogs that we have posted on our website from frontline workers around the globe. I do apologize for the technical problems we had when we first started showing the vlog at the beginning of the webinar. I'm hoping that as the webinar progressed, these technical problems largely resolved themselves. But there are some really fascinating blogs that we posted on our website from Argentina, from Japan, from Ireland, Puerto Rico, the United States, the UK, Italy, the Philippines, Chile. So please take a look when you have a chance. And remember that today's webinar is being recorded and will also be posted on the IPA website along with these vlogs. Okay, final thoughts then. Let me bring to your attention that our journal for IPA, International Psychogeriatrics, is coming out with a special edition wholly devoted to the COVID-19 pandemic and its impact on geriatric mental health around the world. So please keep an eye out for that. In addition, we've posted on the IPA website a whole bunch of COVID-19 related resources to give you more information about how to support yourselves, your colleagues, and of course, how to best support your patients and their families during such a challenging time. And I'll conclude by reminding everyone that given the realities of the situation, the next IPA Congress will be held virtually. It's scheduled for October 2nd and 3rd. And we're very excited about the way the program is coming together. So I would urge all of you to please stay tuned and register for this virtual Congress. Okay, well, I'm watching the clock. I think it's time for us to now wind down. I'd like to thank you all for joining this webinar, and I would encourage you to participate in future IPA-related activities. Thank you, and enjoy the rest of your weekends.